So I'm here today to tell you a story. Okay? And the story is, we are in a brave new world. Food gets delivered at home by talking to a speaker, and an AI will soon educate us better than decorated university professors like me, for example, right? And everyone has realized that health and well-being is the important backbone, and it cannot be left to traditional instruments or devices anymore to ensure that we are all healthy at scale. So let's start with this. Let's start with this wonderful example of behavior change that happened a few years ago, where in Romania they put near the bus stand, they put a computer vision driven box. That box measures, if you do 20 squats, it issues you a free bus ticket, right? And it was a way to encourage or nudge people to participate in healthy behavior actions that led to immediate reward of getting a bus ticket. But Romania is not alone, and Romania is not the forefront of some of this as well. In fact, right here in Singapore, for many years now, the Ministry of Health and various other ministries in the government have been working on this. So Singapore has been declared, in 2016, Singapore declared this war on diabetes. And it was then estimated that 23% of the population could have type 2 diabetes by 2050, severely increasing the burden of disease on one of the smartest cities in the world, right? And so there were a lot of initiatives. There was a lot of public as well as private institutional support for making sure that the citizens and residents of Singapore are aware about the implications of this on their healthcare systems. Since then, technology and innovative AI, for example, has played a significant role in helping Singaporeans battle both prevention as well as progression of chronic conditions like diabetes. They even gave out business class flight tickets to residents to fly anywhere in the world, provided they completed 10,000 steps for a certain number of weeks, right? So that's how innovative some of these initiatives are. But how does this all come together? Particularly, what role do we as computer scientists and artificial intelligence researchers play in this development of a smart city technology that includes components of public health, for example? So any smart city is envisaged to have 4 basic pillars. Its social infrastructure, its physical infrastructure, its institutional infrastructure, including governments and economic, and the last one is the economic infrastructure. So the center of attention of each of these pillars is obviously the citizen. In other words, smart cities work towards ensuring that the best of the entire people potential is brought forward, with all of these pillars systematically working together. And I'm sure we are going to have a lot of interesting discussion in the panel after this talk, where we are going to hear from other experts that have worked on smart city initiatives and how to bring each of these pillars together. So I will not spend time on that just now. I would like to focus a little bit on the social infrastructure and how important healthcare in particular is for that pillar. So just to give a little bit of a background on my own journey in healthcare, since over a decade, I have been working in developing machine learning models for different use cases within healthcare, from all the way from predicting complexities of or dynamic risk scoring of patients in neonatal ICUs at birth or immediately after birth, all the way to predicting hospice care and end-of-life transitions in cardiovascular patients is some of the work that I've done over the years. And by no means is any of this enough, because what I'm about to show you is how none of this actually sometimes works, okay? So sometimes it does work, but most of the time, clinical deployments of these type of one-off machine learning models do not work, do not scale, do not traditionally transfer across national boundaries. So when we think about smart cities and we think about smart health, this one machine learning model fits all localizations and transfer learning doesn't really apply, right? So what did I learn from this, right? So even after decades of helping machine learning and AI and cloud penetrate into the healthcare market, adoption has been very limited. A large number of models which are developed are not really used in practice. In fact, there is a very popular study that was done where they studied over 600 different predictive models that were built for COVID during the pandemic. None of them are in use in practice anywhere in the world. So imagine the amount of time, effort, cost that we have invested in this to no outcome, right? In fact, in a similar vein, Epic is a large electronic health record system, and it's one of the largest EHR companies in the world. They started building out this out-of-the-box sepsis prediction model that they shipped with their product, and they had to stop it, and they had to begin retraining their models using local data from each hospital system based on the pattern that they had observed in their global model. So there are three main problems of large-scale deployments of machine learning in healthcare. One is the lack of generalization. So traditional AI models don't generalize well across cities, across nations, across conditions. The high cost of maintenance of some of these models is extremely challenging for economically challenged countries. For example, developing nations just cannot afford a machine learning pipeline to be deployed at scale because the compute cost that a cloud platform may require in order to adopt that technology itself may be too high, too burdensome, right? And the third challenge is this limited adaptability, because traditional AI models are not adaptable to new problems. So is there a way that we can solve these problems is really the question that we as AI researchers should be asking ourselves, right? So how to break this? But before we break this conundrum and figure out the solution, we first have to think about what we are solving for. And in my opinion, today we are solving for a very diverse patient journey. The pandemic has proved one thing. It has proved that people are not going to depend on to get care inside the four walls of the hospital. So what was a traditional break-fix model where when you got sick, you went to a healthcare facility, got seen by a physician, came home with a bunch of medicines, did a bunch of lab tests, and hopefully recovered, is a completely broken model of healthcare, which is now being disrupted because of COVID. So there is a whole new ecosystem of care and well-being and health developing outside the four walls of the hospital. And that presents huge opportunity for machine learning and policy research as well. The second thing that is happening at scale is this notion of large language models, generative AI, or foundational models. So just a quick check in the room, how many of you have tried ChatGPT or something similar? And this talk would not be called successful if I did not mention ChatGPT at least once, so I will check the box and mention it. But my attention is more on foundational models and what they involve. So, for I think everyone in the room, knowing that you are AI researchers and have a background in machine learning, probably understand that ChatGPT-like technologies or foundation model technologies, they are trained on very broad data sets. And it's perfect for initiatives like smart cities, because smart cities by nature, by policy, actually envision to gather broad amount of data. So that's the fantastic part about this, right? The other nice thing about foundation models is that once built, foundation models can be adapted very quickly to myriad downstream use cases. So you train once, you build a model, it's a large model, it's expensive, but it can be adapted very fast for downstream use cases. And then, tons of examples of that, but let's go into some of the details of what it can do, particularly in healthcare. So the first thing that a foundation model is promised to be very successful at is this idea of multimodality. So far, machine learning models, particularly even deep learning models, have been constrained by the type of data that they can handle. For the first time now, we are seeing a lot of research happening in the deep learning community where you can combine text with images, with voice, etc. Now, that's not to say that multimodal machine learning was not happening before deep learning or foundation models came along. There's a lot of great research work that has been done on combining data types in order to build classification models, clustering models on heterogeneous data. There's no doubt about that, right? But there is now a paradigm shift in the way that this can be done, where the main constraint of having good labeled data across modalities, which was a big restriction, has now starting to get overcome. So you can have different amount of sample label data across different modalities in order to then combine and learn from these together, right? So that's the big change that's coming in terms of pros. So for healthcare, obviously it's going to be a huge disruptor because healthcare is very ripe for this multimodal architecture. The second thing that foundation models are promising to do for healthcare is their ability to be reusable once trained. So even though these models are very expensive, and I've said that now many times, but they are easily adaptable to new tasks where you can train the model once, so you can have a medical foundational model, and then you can reuse the components of the model, and you can define smaller models for task adaptation that can then be quickly put into production. And the nice thing about that is the localization effort that is needed oftentimes is much less compared to the traditional model that we were using before, right? The third thing that foundation models are promising to do in healthcare, and the jury is still out how much this will succeed, is the idea of generalization. And as we have seen very recently in the news, large language models are still struggling with that concept of generalization to be acceptable at scale. But they can be applied for multiple populations, multiple use cases, and multiple problem types without having to retrain them again and again and again on the data, right? In fact, medical foundation models have been reported to reduce training requirements on new tasks by a factor of 10. That's a huge improvement if you want to get a machine learning model, for example, 510K cleared, or put it in an FDA approval setting, right? So it makes it very fast for an AI-driven therapy, right? So let me shift gears, because I want to bring attention back to the example that I gave earlier on what Singapore is doing or what Romania is doing. Fundamentally, smart cities, smart health is trying to change behavior of people at scale. And in order to achieve behavior change at scale, we need to depend on a technology, or rather a behavioral economics construct called nudging, nudge theory, right? So what is nudging, and how do you now marry the concepts of broad big data, traditional AI as well as foundation models to this concept of behavior economics called nudge theory. So in nudge theory, a traditional way of pre-intervention would be that someone wakes up, has their breakfast, goes to the office, and then comes back to their home. Whereas there is, in nudge theory, there is an intervention pathway where you nudge someone slowly to change their behavior, and then that behavior change leads to actions that are different. And hopefully, the expectation is that this change in behavior will be sustained. And what I'm about to show you or talk about is how AI can help with this sustainable post-intervention behavior change at scale that was not possible just a few years ago. So how does it work? Well, it works by first personalizing the prediction on a patient's health progress, right? So if you have two people, both of them have high BMI, obese, smokers, instead of the traditional way of a smart city, smart nation, smart health approach, where you put out big banner ads on buses and on MRT stations, now can you do something different where you nudge people in a very personalized manner to then change the behavior of each individual and put them on the pathway that they are most likely to take rather than the blanket construct. And in order to do that, we need to understand what is the traditional view of behavior change. So behavior change typically is top-down, or traditionally people thought about behavior change as top-down, where the government should enact a policy to drive this change in society. For example, if people are getting fat and obese because they are eating too much sugar, the government can decide that one day we should put more tax on sugar, we should ban sugar, we should not let people, eat or drink sugary foods. But that's not going to work. It never has, because we are humans. We are not rational actors, right? We are, genetically wired to be irrational actors. And so every person has free choice. And if you educate them about the potential harms of consuming too much sugar, that seems to be the right way to go. And, that's the idea behind, the Nobel Prize winning theory of Dick Taylor, where he and Cass Sunstein introduced this idea of an alternate view of behavior economics, where you take a more realistic view on human nature and you apply behavioral science to study the economic outcomes and reasonings of why people behave irrationally, right? And it can help foster change much better. So how does that then merge with this idea of smart nudging? And what is a smart nudge? So a smart nudge is a subtle change to any aspect of the choice architecture that alters people behavior in a predictable way. So it's very important to make sure that it is in a predictable way without forbidding any options or significantly, changing their economic incentive. So to count as a mere nudge, the intervention must be easy, right? It cannot be, a big stick, and it has to be cheap in the sense that the overall total cost of, implementing that nudge has to be somehow relatively, more economically beneficial than enacting the law or forcing people to do it in some other way. And this is not my sentence. This sentence is actually Dick Taylor and Cass Sunstein's sentence from 2008. So what is a nudge in healthcare then? A nudge in healthcare is also a subtle change in the choice architecture to influence a person to improve their health outcomes. And a nudge could be, for example, targeted at clinicians. So don't think of nudging only as something that has to be done to people, patients or consumers or members. There is a whole field of something called operational nudging, where you nudge the actor that is going to act on the consumer in order to then improve the outcome and the behavior, right? And then, for example, nudge could be to a clinician to not overprescribe or provide better care or do it quicker, pay attention to a patient's lab test in time so that they can then be discharged from the hospital in time. It can be to a primary care, clinic, diabetician or endocrinologist or a pulmonologist to pay more attention to a certain part of the population. And I know in Singapore, there is a huge initiative that the government has recently launched on something called Healthier SG, where the idea is that members of public will then identify a particular primary care provider and then work with them in a sustained manner to engage in a behavior change practice, both from the clinical side as well as from the patient side. So nudges, are very useful in, for example, randomized clinical trials as well. So, question is, do they work, right? Like, does all this investment, is it warranted, and do they work, right? Well, first of all, human brain typically has, two parts to it, and deviating from the default also creates a lot of uncertainty around the decision that needs to be taken. So it is usually useful to make defaults as norms. So people accept something that is default as normal, right? So the psychological mechanism behind this is called inertia and refers to the fact that individuals prefer sticking to their existing or standard behavior rather than doing something different or involving an effort that involves a choice, right? So you'd rather not make a choice if you can avoid making a choice, right? So, and there is a whole nudge intervention ladder towards the bottom of the ladder is this focus on delivering information, just educating. And then at the top of the ladder are sort of these interventional approaches that are more in the face. They guide choice through default options. For example, in the US, very successfully, a few years ago, several states adopted the policy of making organ donation default yes rather than default no. And that led to huge number of, transplant patients getting organs that they were otherwise not benefiting from. So a very simple choice architecture change actually led to good outcomes, right? And as computer scientists, we like to measure everything, we like to test everything. So how do you test the efficacy of a nudge, right? So you can either rely on some theories of human behavior, or you can define these choice architecture aspects as controlled experiments of some sort, and then you can run these massively parallelized, a multi-arm bandit type of scenarios on these experiments to then gather data. And this is something that most technologies companies have been doing at scale now for over, almost 2 decades, right? At a government level, in the interest of time, I'll not go through all of that, but this idea of nudge theory and forming what is called as a nudge unit came around in 2008 timeframe, 2009 timeframe. David Cameron's administration in Britain was one of the first ones to establish a nudge unit at the governmental level. And then the Obama administration followed that up in 2012, 2015, and had their own nudge unit for helping improve outcomes across multiple use cases, from finance to healthcare to public policy, right? So why does this not work yet, right? And the key question is, how can machine learning and AI help make it work at scale? And when we say scale, we say nation scale, right? The first bottleneck or the opportunity for AI is, how do we enact this behavior change at scale? How do we ensure that people are getting the right set of nudges if there are millions of people, right? And this is not just a multi-objective optimization problem, it's actually a software scalability problem, where you need to not just send a nudge, or personalize the nudge, or sort of provide the right nudge at the right time, but also very important to collect the feedback on how that nudge is working, what's going on, and then change those behaviors. And then some would always argue that nudges don't work, and there is a whole meta-analysis that I can share with you. Bottleneck 2 is using data and AI to change the defaults. So can we live in a world where certain subsets of the population have one particular default and other subsets of the population have other choice as the default, right? So think about it. This is, when we talk about default, we actually mean default for the whole population. But now can you design using AI certain optionality where defaults are different for different subgroups of the population? And how does that then impact health equity, fairness, bias, etc.? So that's a big challenge. The third big challenge that AI can help solve is what we call as hyperbolic discounting. Individuals, all of us in the room and online, prefer earning less money immediately rather than seeing more rewards in the distant future. So, for example, if we said, "I'll give you $50 now to do something," or $100 in a year's time, most of us in the room will actually take the $50 and run, right? So that's how we work. Now, AI can actually help decide certain policy decisions that can then dish out that on an incentive, on an incentive scale that can then help determine which individuals in the population have a tendency towards short-term rewards versus which ones have a tendency towards long-term rewards, and develop that behavior more sustainably. So here is an experiment on thirsty subjects, and the idea is that everyone has a choice. You can get one nice glass of cold orange juice now, or if you wait for 5 minutes, then you can get 2 glasses of orange juice, right? And then the second experiment is to have the same choice, 1 glass of juice in 20 minutes versus 2 glasses of juice in 25 minutes, right? Which one do you think, or for the first experiment, it was observed that 60% of the people, just picked option number 1, took their glass of juice and walked away, right? But if you made that time horizon a little more, then that percentage, dropped from 60 to 30, where people actually, 70% of the people said, fine, I'll wait for 25 minutes, give me 2 glasses of juice, right? So the learning from there is that 5% discount rate is 50% in the long discount, and discount rates are higher in the short run than in the long run, right? Bottleneck number 4 is really what we call as loss and risk aversion, where we humans have reluctance to accept the potential loss. So we would rather not have something than to have it and then lose it. So now you can imagine a foundational model that is ensuring that for a large population, this loss aversion ratio is balanced by providing the right set of incentives in a manner that you don't feel like you are losing something, but rather you are gaining something. The fifth bottleneck is that no one nudge for all approach fits. And we've already seen this in Netflix. We see this on Google every day. We see this in Spotify, where recommendation engines have gotten really, really good at providing personalized recommendations for commodity, content-driven choice architectures. To take that approach of enabling personalized content and scaling it up for national level initiatives like healthcare is still a big challenge, but there is much work that needs to be done and is being done in order to address that. So overall, the solution for this, as I like to call it, is algorithmic nudging. And the idea is that use AI algorithms to adaptively nudge people at scale and reduce some of these bottlenecks that I talked about in the talk. So 3 challenges or opportunities I want to share with you all here. The first one is investment in experimentation and automation at scale. The second one is personalization at scale. And the third one is this idea of multi-arm bandits to conduct huge, level of parallel nudging experiments that can be done in a very intuitive manner today, right? So you can create, and we now have technology that can allow us to create these experimentations and automations. We can, certainly divide the population into relevant cohorts very quickly using data analytics, software, and then discover which of these nudging groups are behaving in a certain way that is beneficial from the phenotypes they already represent from raw data, right? And the last one is this idea of multi-arm bandit, where you can run a smarter, complex version of an A/B experiment. So you can take the same nudge, but you can vary that across different tonalities, different content, different incentives. And then instead of running that one experiment first and then trying another one and trying another one, you can literally now populate this across the population. And the same person can now get to react to 3, 4, 5, 10 different types of nudges and then see which ones they best react to in real time, right? So I'll give you an example of a simple healthcare use case, just to end the talk. And this is the example of, in orthopedics, the idea that patients who are going to go through hip and knee replacement surgeries should somehow, get nudged to then observe their behavior using trackers like Fitbit or Apple Watch before the surgery. And then a surgeon or a physician assistant onboards them onto a pathway of behavior analysis on how much they are walking, what is their sleep, what is their anxiety. And then the surgeon conducts the surgical operation, replaces the knee, let's say, and then you use AI-driven nudging to monitor and remind the patient to go for physical therapy, for example, which is extremely important in orthopedic cases like hip and knee replacement. And then that whole behavior cycle leads to faster improvement of range of motion of the patient, as well as very high level of patient satisfaction scores for the health system to come back. So that's just an example. I mean, this is some of the stuff that we are working on, and other than some of the other stuff that we are also working on. But the future is kind of here, in my opinion. We already are in a deep need for building a foundation model for this type of nudging at scale, and I look forward to collaborating, contributing to this field over the next decade or so or more. And if there are questions, happy to take it. Also, I'll share some of these slides if anyone wants. So just feel free to email. All the references, etc., are provided. Thank you.